good morning and welcome to the Ministry of Health Virtual Media Conference, your source of accurate and up-to-date information on the national COVID-19 response. With us today are known faces, the Honorable Terence Dayal Singh, Minister of Health, Mr. Davlin Thomas, CEO of the North Central Regional Health Authority, and Professor Christine Carrington, Professor of Molecular Genetics and Virology, and Head of the Department of Preclinical Sciences at the Faculty of Medical Sciences at UWI. I'm Candice Alcantara, Manager Corporate Communication at the Ministry of Health, your moderator this morning. We go straight into the clinical update and opening remarks from the Minister of Health.
Thank you very much, Candice. Good morning to CEO Davlin Thomas, and good morning to Professor Carrington. Good morning to ladies and gentlemen of the media and the viewing and listening public on this beautiful but wet Saturday morning, but we will get through. Before I start, I would like to recognize the contributions of two of our ladies. First of all, I would like to recognize Miss Aisha Chow, who was our first athlete, I believe, to perform at the 2020 Olympics and seems to be doing well. Congratulations to you. And I think all Trinidad and Tobago is rooting for you. Good luck to you. Coming into Port of Spain this morning, I was listening to Isaac 98.1. The music was soothing and uplifting as usual. And I heard that today is the homecoming ceremony for their founder, Reverend Dr. Margaret Elcock. I would also like to recognize her contribution to the national landscape of Trinidad and Tobago and wish the station and her family all the best. I would also like to recognize again, and we must always do this, our healthcare workers. You have been a beacon of hope in this pandemic, a year and a half. Thank you to all our nurses, doctors, every classification of healthcare worker. Lab techs, patient care escorts, everybody, ambulance drivers, wherever you are, thank you, thank you, thank you. As you would have seen yesterday, when we launched the Napa site in conjunction with the private sector, again, many thanks must go out to the private sector for working with us. And all the volunteers, whether you are in the public sector sites or the private sector sites, we have people coming out and working for free, from doctors and nurses to everybody. People sanitizing, working for free. People are leaving their jobs, their day jobs, to come and work for free. I just want to thank you. It is heartening to see the response of everybody in the public sector and the private sector to this. People are giving up their income in their private sector work to come and work at these sites. I mean, it has been a wonderful response by the national community. So I just wanted to open with those few words of recognition to two of our ladies and word of thanks to healthcare workers. It is my unusual privilege to give the clinical update this morning. As of 23rd July 2021, total persons tested to date at both public and private facilities, 258,401. New positive cases reported in the last 24 hours, 181. Total positive cases for COVID-19 from the 12th of March to the present, 37,065. Total patients in hospital, 314. Total persons in home self-isolation, 5,212. Total patients in state quarantine facilities, 106. Total patients in our step-down facilities, 76. Total number of deaths, 1,026. And our deepest condolences, as we always say, to these families. These are real persons. These are not statistics. while the 1,026 is a statistic, it is not a statistic to the families who have lost these dear loved ones. So our deepest condolences to those families. Total number of active positive cases, 5,783, and the total number of recovered patients, 30,256. So that's the clinical update for this morning. As is customary, I would like to report on the vaccination drive and where we are. So if I could have the first slide up, please. Our total first dose application is 326,226. Across Northwest RHA, they have delivered or administered 46,207. North Central RHA, 64,917, which is one of the second best performing RHA. ERHA, 39,491. Southwest RHA, which is the biggest RHA in terms of population that they serve, 69,634. TRHA, Tobago, 11,074. State agencies, 11,131. That will be agencies like Trinidad and Tobago Defense Force, who have their own facilities and so on. Other agencies, a lot of these other agencies will in fact be the private sector, Supermarket Association, Medical Association, TTMA, Donna Diwali Nagar, and now as we add more like Proman with their drive-through, Napa and so on, 83,822. So if the math is correct, you get 326,276. Total second doses so far, 179,382. If you could go to the graph now, please, which is what we always look at. This is what we have been setting as targets. The horizontal mauvish purplish line. We had set this target some time ago as our initial target based on the vaccine availability at the time, which was 188,900. So that was our first target, our first goal to be achieved by the end of July. Where are we at now? The green line represents the total number of persons with one dose. What is good about the green line, you would see in recent days it has gone almost vertical. So currently we are 326,276. What we would like to see with that green line in the coming weeks and months is that it translates into second doses, which is where we go now to the aquamarine line. The aquamarine line is almost touching the horizontal purple line, which is our first goal of 188,900. We are currently at 179,382. So it means, percentage-wise, we have achieved 95% of our first goal. While these numbers are what they are, we have to keep up the vaccination drive. The vaccination drive and this 188,900 is not a destination. It is one stop along a journey. And that journey continues after, hopefully, we meet that target. That is not a destination, the 188,900. That is just one stop along a journey to vaccinate as many hundreds of thousands of persons as humanly possible, so we could save lives, we could save jobs, we could save the healthcare workers, we could prevent healthcare workers from getting more exhausted than they are, because they are all tired. All our nurses, all our lab workers, they are exhausted, they are tired. Ambulance drivers are tired. Doctors are tired. Patient care escorts are tired. When we visit facilities and speak to them, they are prepared to continue working, but they are tired. And this is across the world. So that's the clinical update for this morning. That's the vaccination drive update this morning. Let's continue with the vaccination drives. So Candice, thank you, and back over to you.
Thank you very much, Minister Diazing, for bringing us up to date with what's happening with vaccination. And as we discuss vaccination, my apologies, I hope you can hear me now. Thank you very much, Minister. As we go further into this morning's conference, we're going to hear from Mr. Thomas, CEO of one of the regional health authorities, and our RHAs play a critical role in the vaccination rollout for Trinidad and Tobago. Let's go to Mr. Thomas.
Thanks, Candice. Minister, the Honorable Terence Dialsing. Minister, the Honorable Mr. Terence Dialsing. Professor Carrington, virologist, University of the West Indies, members of the media, staff of TTT, members of the public, good morning. Here are some of the highlights of our recent vaccination of activities. We've increased our distribution network to include 5 health centers and a drive-through vaccination site. The 5 health centers that are now providing additional vaccinations as part of the network are the Blanchisseuse Health Center, the San Rafael Health Center, Talparo Health Center, Macoya Health Center, and the Tacarigua Health Center. And now we also have the Wallerfield Raceway at Wallerfield, Trinidad. We want to thank as well the Trinidad and Tobago Automobile Sport Association for providing the site. So we invite you to take a road trip and continue to utilize the drive-through. As a milestone, we've already crossed the 2,000 soft testing phase, and so we're happy to announce this morning that no appointments are necessary anymore for access to the Wallerfield site. So you can go down to Wallerfield and have your vaccinations in your car, and we'll take care of you from there. We as well want to highlight the National Libraries and in collaboration with the National Libraries and Information Systems Authority to assist with data entry and simultaneously providing us with call center services, so that they will now facilitate our appointments process for second doses, and they have already been doing so. And certainly we'd like to thank the chairman of NALIS and the executive director and the deputy executive director. Thank you. And as well to thank the staff and the volunteers who operate within the NCRHA, who continue to engage with preponderance and passion. There's a Dropbox service that is also available at the health centers. You can collect your forms at the health centers. Simply fill them out, put them into the Dropbox, and those will facilitate the appointments. In terms of our total, just the breakdown, further drill down in terms of the doses that we've administered, in terms of finish as an RHA, in terms of Sinopharm, first and second dose, at least about 67,000 between May 21st and July 23rd. AstraZeneca vaccines, we've totaled 37,429 to date, and the NCRHA has delivered at least 104,000 vaccines between the 23rd and the 21st. During the period July 26th and August 16th, AstraZeneca second doses will be administered at the UTT site at Monroe Road in Chaguanas. Those persons are being called, and we anticipate that within that period we will facilitate 100% of those persons who require their second dose. The Elderly Express experience has been ongoing, particularly to facilitate those persons at elderly homes and those persons who are shut-ins. And we've increased that number of persons who have been affected and vaccinated to 886 persons, which again accounts for about 98% of the homes within our catchment area. Thank you very much, Candace.
Thank you very much, Mr. Thomas. A real whole of society approach there. We heard NALIS, the Automobile Association, we heard volunteers, and of course the staff of the NCRHA all working together to vaccinate TNT. We're very grateful as well to have with us the ongoing expertise from Professor Carrington. And today she's going to tackle a very topical subject matter: Sinopharm vaccines, COVID-19 vaccines, and the Delta variant.
Thank you so much, Ms. Alcantara, and good morning, Minister Dial Singh. So thank you so much, Ms. Alcantara. Good morning, Minister Dial Singh and Mr. Thomas, and also good morning to the listening and viewing public. Now, like all viruses, the SARS-CoV-2 virus, which causes COVID-19, it changes over time, because every time it infects a new person and starts copying itself, there's a chance for changes to occur. And these changes are called mutations. And a virus with one or more new mutations is sometimes referred to as a variant of the original virus. Now, some variants are of concern because they spread more quickly, or because they cause more severe disease, or because they more easily escape the body's defense systems. Now, the Delta variant, which was first detected in India, is one of these variants of concern. To date, we have not detected a Delta variant in Trinidad and Tobago, but given its prevalence around the world in different countries and also its presence in the region, it is really only a matter of time before it gets to Trinidad and Tobago. The Delta variant is known to spread more quickly because this is because the time between somebody being exposed to the virus and actually becoming infectious themselves, being able to infect others, is shorter than for other variants of the virus and the original virus, the ancestral virus. And also the virus levels that it tend to get higher with the Delta virus. The levels of virus in your body, they get higher with the Delta virus variant than with other variants. Now, if you get infected with SARS-CoV-2, whether it's a variant or not, your body's immune system fights back. But, very importantly, it takes time for your immune system to work out the weaknesses of the virus and to produce the right tools to fight the virus. And during that time, the virus can get the upper hand, and as we know, all too often the virus wins that battle, resulting in severe disease, hospitalization, and sadly, in some cases, death. Now, the COVID-19 vaccines, they train your immune system by presenting your immune system with material that looks like the virus. So your immune system has an opportunity to prepare in advance of infection. And after vaccination, your immune system basically knows what the enemy virus looks like and has already prepared a stockpile of tools to fight the virus. And those tools include things like antibodies, B cells, and T cells. So if you're vaccinated and you do get infected, the chance of you ending up in hospital or dying from COVID-19 is extremely low, and much, much, much lower than if you were not vaccinated. Now, the vaccines that we currently have were designed against the original, the ancestral SARS-CoV-2 virus, and we now have variants that look slightly different from that original version of the virus. So it's not exactly the opponent that the vaccines train your immune system for. But very importantly, over and over again, we are seeing evidence that although some variants can partially evade the vaccine-induced immunity, the vaccines still work well enough to massively reduce the chance of severe disease, hospitalization, and death. Now, moving to the Sinopharm vaccine itself, now clinical trials prior to its approval showed that it is very safe and it provides excellent protection against severe disease, hospitalization, and death. However, at the time when those trials were done, the variants either had not arisen or they were not in such wide circulation. So it's important for us to work out how well the vaccine works. And this vaccine, the Sinopharm vaccine, and other vaccines, it's important for us to work out how well they work against the variants. Now, there is already some real-world data suggesting that the Sinopharm vaccine is effective against specific variants. And now, recently, we have a study from Sri Lanka that adds to this body of evidence. The study, which at this stage has not yet been peer-reviewed, it investigated how the immune response induced by the Sinopharm vaccine performed in general and against 3 variants of the virus. They looked at the Alpha variant, that was the one first identified in the UK, the Beta variant in South Africa, and the Delta variant, which I've mentioned. Now, firstly, the study, which involved 323 individuals who received the Sinopharm vaccine and 36 individuals who had been infected with SARS-CoV-2 naturally. They have just become infected themselves. They found that the Sinopharm vaccine was extremely good at producing antibodies against the virus. 95% of the study participants developed antibodies against SARS-CoV-2 after 2 doses of the vaccine, and it worked equally well in people with and without comorbidities, so they all responded well to the vaccine. In 81% of the vaccinated individuals, those antibodies included antibodies that block the virus spike protein from binding to a protein called the ACE receptor. Now, that's the protein that the virus uses. It binds to that protein in order to enter your cells and start replicating. And so these 81% of people had antibodies that block that interaction. So a high rate of antibodies with the potential to block infection. The rate was no different to what they saw in people with natural infections. So basically, with vaccination, you have the opportunity to get an equivalent immune response without the risk of disease that comes with natural infection. They then looked at specifically at antibodies against the part of that spike protein that actually interacts with the that receptor, that protein that sort of allows it to get into cells, and that's called the receptor binding domain. And some of the mutations that you find in the different variants, they occur in that region of the spike protein. So they looked specifically at that and looked to see how well the antibodies produced by the Sinopharm vaccine could recognize those that region in the different variants. The results showed that after 2 doses, over 85% of people who were vaccinated had antibodies that could recognize and bind that receptor binding domain of the ancestral virus, as well as the Alpha virus, that's the one they first found in the UK, and the Delta variants. The performance against the variant from South Africa was not as good, but still at a level that you would expect to get protection. So we're seeing that the Sinopharm vaccine is working well against these variants. And also in that study, they didn't just look at antibodies, they looked at other arms of the immune response. The immune response is not just antibodies, and they found that there was a robust T cell and memory B cell response. It was that arm of thing was not as weaker than some other vaccines, but enough to provide good protection. And one thing I wanted to add, actually, the levels of some of those antibodies was lower against the variants compared to the ancestral virus, and you will see headlines in the media that highlight this aspect, that you get lower levels of antibody. But if you read past the headlines, you will see that, especially in the case of the Alpha and Delta, that reduction was small, and it was comparable to what you see in natural infection. So in summary, the Sinopharm vaccine is expected to be protective against the Delta variant and also other variants. Now, in addition to protecting you against severe disease, hospitalization, and death, vaccines also reduce the chance of spreading the virus to others. They don't eliminate it totally, but vaccinated people are less likely to spread the virus than unvaccinated people. Now, the Delta variant, as I said, it spreads very quickly. The Sinopharm vaccine is an opportunity for us to get out ahead of that variant. We need as many people as possible to go out and get vaccinated so that we can protect ourselves. So I encourage everyone to take your vaccine for your sake, for the sake of your loved ones, and for the sake of your country. Thank you.
Thank you for Professor Carrington, and you've heard it from the professor. Please go out and be vaccinated once you are eligible to be vaccinated. Let's protect ourselves and protect each other. And we go now into the question and answer segment. Media representatives, please indicate your name and the media house that you represent before posing your 2 questions. Please, if you have 2 questions, ask both at the same time so things can move forward as quickly as possible. And of course, if we have additional time, we will come back to you if you have more questions. We start this morning with 98.1 FM. Are we ready with Mr. Cummings? I think maybe there may be some sort of technical issue, so we'll go to AZP News and come back. AZP News now, please.
Good morning, Private Harry, azpnews.com. My 2 questions are for Professor Carrington. Professor, last week there was a study by the UK that showed that the AstraZeneca vaccine could give you lifetime protection against the COVID-19. What is the latest in that? Are we about to accept that view? I don't know. Could you shed some light on that? And also, there is another variant of interest, B1621. Should that also be of some concern to us in this part of the world now? Thank you.
Okay, thank you very much. So the first thing you asked about was lifetime protection by AstraZeneca. I don't think at this stage anybody can confirm that any of the vaccines we have can provide lifetime protection. There may be indicators that that is the case, but I don't think anybody can confirm it. And I think that's what I'll say about that. The B1621, yes, that is another variant that has arisen. It has quite a number of mutations in it. And it was first, I know in Europe, they had it under surveillance for a while. And it is now considered, it's a variant of interest. So yes, it is one of the variants that we have to look at. There are several others. Now, as the virus, when you have high levels of virus circulating in a population, there's more opportunity for variants to arise. So there are quite a few variants of interest, and also what the WTO refers to as alerts for monitoring. So we have to keep our eye on these things as well. The more people we get vaccinated, the less virus there is in circulation and the less chance for variants to emerge.
Thank you, Professor. We go now back to 98.1. And we're ready for Mr. Cummings.
Yes, good morning to you, Ms. Alcantara, and of course, Minister Dayal Singh, Professor Carrington, and Mr. Thomas. Stephen Cummings, 98.1 FM. Just 2 questions quickly, one for Minister Dayal Singh and the other for Mr. Thomas. Minister, I'll pose the first question to you. Someone wrote me an extensive note that they got a fit for work document from a doctor in relation to the COVID-19 testing, but never got an official test result for the virus after being quarantined on discovery of being a secondary contact. Who is responsible for issuing an official COVID-19 test? Is it the health center to which this person attended, or is it the doctor from whom a test was rendered? And secondly, Mr. Thomas, in terms of the deployment of staff, and you talked about the expansion of these centers, and I know we had a discussion earlier on about staff being overstretched. What is the formula going forward for this expansion initiative? And I'm not necessarily talking about the private sector involvement, more so the professionals, the doctors, and who are the ones supposed to be spearheading this initiative. What is the formula like in terms of the deployment of these professionals? Thank you.
Okay, thank you very much, Mr. Cummins.
Minister, just press the...
Oh, sorry, I forgot to press the button here. Thank you very much, Mr. Cummins. So the test results are the responsibility of the agency and or doctor performing the test and giving the results. So if it's at a health center, and Mr. Thomas can support that, they are the ones responsible for the test. If it's a private sector lab, they are the ones responsible for giving the results. As far as your Fit for Work program is concerned, as we always advise the media, when you have these letters from individuals, we are anxious to find solutions. So send that individual's name and phone number to us, and we will run it down and try as much as possible to assist. But generally, I believe those Fit for Work will come from the offices of the county medical officers of health. Mr. Thomas, is that correct? Yeah. So, thank you very much, Mr. Cummins. Thank you very much for your questions. But send the person's name and phone number to us, and we will try to assist them. Thank you.
Thank you. We go to Mr. Thomas for response to the other question, please.
Well, in terms of the inherent capacity, that has been the increase in the capacity inherently at the NCRG had been accommodated, well, as you know, as you mentioned, by volunteers. There's also the additional legislation that now facilitates that we utilize MLTs, who are medical lab technicians and radiographers, to provide vaccinations. And certainly, because we've had quite a number of opportunities to prepare for this, we would have anticipated where we can redeploy staff from areas from which we provide less services, or some of the elective services. So it's a combination of redeployment simultaneously with the fact that we have new categories of staff that we can now utilize non-traditionally, and certainly we have had some incremental increases in staffing. We have had a few more doctors and so on, and in particular as well the nursing interns. So thank you.
Let me just, from a ministry perspective, because Mr. Cummins, the issue you raise a very important one: capacity. So since the start of COVID, the ministry via the RHAs would have hired an extra 1,236 healthcare professionals of all categories, all classes. The two that stand out in my memory, because I had to do this for the mid-year review, were about 255 RNs and 246 doctors. In addition, last year, we did a training program for 150 local nurses in ICU training, because ICU capacity needs to be ramped up. In addition to that, we would have brought in over the past year about 42 ICU nurses from Cuba to supplement the shortfall in ICU nurses in Trinidad and Tobago. They are not taking the place of local nurses, because we have always had a shortage of specialty, either doctors or nurses, and that is where the Cuban brigade comes in. So just to recap, a total of 1,236 persons across the different disciplines, which included 255 nurses, 246 doctors roughly, ICU training, infection prevention control training, and more ICU nurses. So I hope that further supports what CEO Davlin Thomas would have said. Thank you very much, sir.
Thank you, Mr. Thomas and Minister. We go now to questions from Guardian Media Limited, CNC3, please.
Hi, good morning. Renuka Singh at the Trinidad Guardian. Minister Dayal Singh, we're seeing, despite the rollout of the vaccination, we're still seeing some vaccine hesitancy among core groups like the restaurant workers and teachers. What criteria needs to be met before the government can decide to reconvene Parliament to look at mandatory vaccines? And my second question also is, what do you think needs to be done with regards to communicating how important it is for the uptake of vaccines to get the economy open, because the government has been trying to communicate this to people, but we're still seeing that hesitancy. Thank you.
Thank you very much, Renuka. So the latest figure I have from the food and beverage industry is that roughly 12 to 15,000 persons in that industry have in fact been vaccinated, which is good. They had initially targeted roughly about 20,000. So they aren't doing too badly, and I'm grateful for that response. On the issue of reconvening Parliament for mandatory vaccines, the Honorable Prime Minister would have addressed this fully last week. It is not on the agenda right now, but as he said, he is grateful for the discussion. Right now, vaccines are voluntary but highly recommended. And I think the pending advent of the Delta variant should add an additional spur, an additional encouragement that if we vaccinate as many people as possible in the shortest possible space of time, we can get in front of this Delta variant. Our objective as a country now, with voluntary, highly recommended vaccinations, is to get in front of the Delta variant. Because as Professor Carrington explained, and we specifically asked her to come this morning to share with you the latest on the Delta variant. We could speak about the Delta variant as much as we want, but at the end of the day, to get in front of it, to make sure it doesn't decimate our population, to make sure it doesn't cripple our healthcare system, just get vaccinated. On the issue of communications, yes, we had a meeting yesterday. As I said when I was at the press conference at Napa, we are rejigging our communications plan. You would have seen we started off with leaders in the community, all the major religions, Catholic, Father Gordon, Reverend Berkeley from the Anglican Church. We had the Maulana Suleimani representing the Muslim faith. Former Chief Medical Officer. A lot of people don't know that Pandit Parasram, the Dharmacharya from Swaha, is a former Chief Medical Officer of this country. So he is amply suitably qualified from both a religious perspective and a medical perspective. We have engaged many local popular leaders. You would have seen Nikki Crosby. And from next week, we are further strengthening our presence in radio and using the Red Cross at the level of community miking. So we are using almost every single communication channel to get people to realize that vaccination against COVID-19, whilst voluntary, it's a choice that you have to make, but with more freedom of choice always comes more responsibility to use those freedoms wisely. At the end of the day, the message is get vaccinated. It could save your life. It will save business. It will save Trinidad and Tobago. Thank you very much, Renuka, for the question and allowing me the chance to answer it.
Thank you very much. We go to Newsday newspaper now.
Good morning, Janelle D'Souza from Newsday. First of all, Minister, we've been vaccinating several sectors and sections of the population. What other sectors of the working population are still to be vaccinated? And the second thing, Dr. Carrington, a lot of people who are hesitant to be vaccinated are saying, well, we can still contract and transmit the disease when they're vaccinated. So what is this herd immunity people are talking about? Can you respond to that?
Thank you very much, Janelle. Nice to hear you again. The sectors that we want to keep on vaccinating, I think this weekend we have a drive with URP and CPEP. One of the other populations we want to vaccinate as a matter of urgency is our prison population. My colleague, Minister of National Security, Fitzgerald Hines, had asked for a 1-to-1 vaccine ratio between vaccines allocated and prison population. At that time, he would have indicated there were 3,750 prisoners, but sadly, we made the vaccines available, but only 10% have agreed to be vaccinated. And persons living in close contact, as you know, are very susceptible to spread. So we are going to be doing some work with the prison service to encourage more and more prisoners to be vaccinated. The doses are there for you. They have been allocated. But a vaccine is only useful if it's in your arm. Having a vaccine on the shelf or in the fridge in the prison doesn't help. It has to be in your arm, and it has to activate your immune response to give you that protection. Another group that we are tackling are farmers and fisherfolk. We continue to tackle teachers. We are tackling again through the Ministry of Energy, Oil and Gas. The University of the West Indies, we targeted them. They started actually yesterday, I believe. So the whole university population, not only students, not only faculty, but groundsmen, security, everybody. So university would have started yesterday, so we look forward to getting those figures. We are targeting through the Diabetes Association all persons not only with diabetes, but they have agreed to work with the Coalition of Non-Communicable Diseases to bring people into their database, and we will vaccinate them. So those are some of the special groups, Janelle, that we are after as we continue on this journey to vaccinate as many people in the shortest possible space of time to get ahead of the impending arrival or detection. Now, as Professor Carrington could tell you, because we have not detected the Delta variant does not mean it is not here, and I would like you to emphasize that point. The fact it has not been detected doesn't mean it is not here. And Candice, I would like you to just go to Dr. Carrington for a brief moment to expand on that point.
Yes, Professor Carrington has the next question. So,
right. So I'll handle the I'll handle the Delta variant detection issue first, and then I'll come back to the question of the herd immunity. So basically, when you obviously were screening samples looking for the Delta variant, first of all, not every single infected person in Trinidad gives a sample to be screened. There are a lot of people who are asymptomatic and don't even know that they're sick. So we don't get every single case of COVID-19 coming to us to be screened for the Delta variant. Also, not all samples are suitable for sequencing, and so you can't detect. You're not going to, unless we screen every single person in Trinidad, you're not going to detect the first case of the Delta variant in Trinidad. There's a bit of a lag time between detection and when a virus arrives in a country. And that is not peculiar to Trinidad and Tobago. That occurs everywhere. You will see this is the first time we've detected it. And then actually, when you look back, you see other cases. And so it's sometimes like 2 weeks, a month, it's been there. Okay? So just because we haven't detected it yet doesn't mean it's not here. So we should be taking this very seriously even now. Now, coming back to the issue of the question that was asked, what is the point of being vaccinated if you can still be infected and transmit the disease to others, and how does that relate to herd immunity? So the first thing I'll say is that being infected is not the same as being sick. You can get infected and not get sick, and that is the aim of the vaccine. So the vaccines want to keep you as healthy as possible. They give you the best chance against the virus should you be infected. So that's one reason to get vaccinated. In terms of transmission, yes, vaccinated people can become infected and can transmit the virus to others, but the rate at which they do so is much lower than for unvaccinated people. And when you're talking about herd immunity, you're talking about a population level of protection. So although there's variation in the individual level, you reduce, once you reduce that in the risk of individuals transmitting, the overall effect on the population is more protection across the entire population, okay? Now, because you still have the chance of transmission, we have to continue with the other interventions, the mask wearing, the distancing, etc., even if we're vaccinated. But the key point is that vaccination reduces the risk of transmission overall and cumulatively across the entire population. So we bring that risk down. We increase the level of immunity in the entire population and reduce the risk of the virus being able to spread. And that way we can contain the virus and, prevent us from having more spikes and stuff. So encourage everybody to get vaccinated. Again, not just about yourself, because you hear people, individuals will say, well, why do you care if I'm not vaccinated? Because you are vaccinated, so what's the point? Why are you bothering with me? The point is that we live in a community, and it's not just all about you, it's about all of us living together in this community. And vaccination is about you, and it's about everybody else. Okay? Thank you.
Thank you, Professor. We go now to TV6, please.
Good morning. Just wanted to get some clarification from anyone at the head table. For those who may be wondering, given the state of emergency, given the measures that were undertaken in terms of the lockdown of many sectors of the economy. Now, we're seeing a reopening of sectors and so on, but yet we're also seeing some of the rates of infection. One may be wondering, well, why we are not yet seeing anything, let's say, below 50 cases per how many days of testing samples. So if anyone can address that, that's the first question. The second question, has the government had any challenges with persons returning to Trinidad and Tobago via the travel pass system that was launched last week, and also in the context of persons who may be using, let's say, a dose of one vaccine and a dose of another vaccine and trying to enter Trinidad and Tobago?
Okay, so I will take the second question first, and then we'll go to Professor Carrington to take the first one. On the issue of returning nationals, any issues? As you would recall, Joel, thanks for the question. The Honorable Prime Minister did indicate last week, Saturday, when the borders were opened for the first time, we did pick up one individual who was trying to work around the system. And he did indicate that he didn't want to get into much more details because it may become a police matter. So that's the one I'm aware of. On the issue of different vaccines, the Chief Medical Officer did indicate last week, Saturday again, that the only WHO approval for mixing of vaccines is AstraZeneca first dose and Pfizer second dose plus 2 weeks after. So that is the official position on mixing of vaccines to be able to come into Trinidad and Tobago to be considered fully vaccinated. Thank you for your question, and I'll now hand you over to Professor Carrington.
Okay, thank you so much. So you were asking why it is we haven't reached down to below 50 cases a day, and we're still around like 150 and stuff like that. Now, the reason for that is, first of all, we are coming down from a very high peak, okay? Now, remember that that infection is an exponential process. It's not I give it to one person and then that one person gives it to one person. It's more like if I'm infected, I might infect 2 or 3 people. They go on to infect 3 more people. So it's an exponential increase in the way that the virus is spreading, okay? So when you try to counter that, it's not a simple sort of linear equation that bringing you down from a peak. You are battling, it's sort of like battling an uphill trend. And so it takes some time. It will take more time. Also, although we have had a lot of restrictions in place. The level of movement in Trinidad, the level of interaction is not really down to zero. So you will still get some transmission occurring. People are still moving about. And we're also trying to balance between, opening up different sectors and keeping us safe at the same time. So it's going to be a slow process, but, we will eventually get down there. And one of the things that can get us there faster is people getting vaccinated. Thank you.
Thank you. The message remains the same. Please get vaccinated. And we're going now into a few follow-up questions. We just have limited time, so please be brief. And we're going to AZP News for one follow-up question, please.
Hi, good morning again. Is Prabhi Hari, AZP News. Minister, I just want to clarify. I think that that the former CMO is the Dharmacharya of the Mahasabha and not Swaha. I think you made a mistake there. So I just wanted to clarify that for you. That's okay.
But if I do apologize.
And my question is for Professor Carrington. Professor, when we now get our vaccine and we're fully vaccinated, I think the learning is that you may have to take another shot within 9 months to a year. So should we make our mind now that we'll have to get another shot next year? What is the learning in terms of that? Yeah, thank you.
Okay, so at the moment, nobody can tell us right now if and when we will need another booster. Now, one of the things now, when a vaccine is approved, a lot of people have concern about this emergency use approval. Let me tell you the difference between emergency use approval and full approval. When you do clinical testing on a vaccine, clinical trials, those that went before, you're looking for three things. You're looking for, is it safe? Does it work? And the third thing is, how long does it work for? So how long will it protect you for? You can give emergency use approval once you've worked out that it's safe and that it works, because we don't have time to wait 2 years to find out if the vaccine is going to protect us for 2 years. It's an emergency. So nobody really knows at this stage how long it will last. However, we do know from other coronaviruses and from looking at the levels of the antibodies, immunity in people who have been vaccinated months and months ago, from seeing reinfection of people who have had previous coronavirus infections, it looks as if, after about, 6 to 9 months or so, you do get a decline in immunity. But it's important to remember that your immune system, although you lose some of those antibodies, your body remembers how to make them and how to make them quickly. So should you get infected again, that disease is expected to be mild. So I don't think at this stage, the WHO, for example, is not recommending boosters at this stage. There may be the chance. And the other thing to add is that if we do not control the virus through vaccination and we have rampant replication of this virus and spread of this virus in the population, the chance of other variants arising that may be even better at escaping the vaccine, that chance increases. So again, the solution, vaccination, bring those virus levels down, reduce the chance of infection, and try and get us out of this.
Professor Carrington, Candice, if you will allow me, Professor Carrington educated us on something, but I think it needs amplification, because there was people are saying because these vaccines have EUL, they don't have faith in it, that somehow it is still on trial, or somehow it is not safe. Could you repeat and amplify the point about the difference between EUL and full approval in terms of safety, efficacy, and the length of time that you have protection for? I think that is a crucial point, because that conversation is circulating in Trinidad and Tobago, and I saw it in one of the newspapers this morning, and it's a very unfortunate misunderstanding of the difference of what emergency use authorization means. So please amplify that point so we could inform the population.
Okay, so as we know, when you are testing a vaccine, you have a new vaccine and you test it, you put it through clinical trials. And we all remember last year when there were trials with tens of thousands of people where they vaccinated some and they gave some a placebo of sort of control and compared how the vaccine, their protection against the virus. So through those trials, you can work out if the vaccine is safe, and that has been achieved. You can work out if it works, does it protect you against disease, and that has also been achieved. And the third thing you want to know about a vaccine is that protection that it provides, how long does that protection last? Okay? So those are the three things. Once you know that it is safe and that it works, if you are in an emergency and you don't have time to wait to see if it works for 2 years or 3 years or, a lifetime, we are in an emergency, then you give this emergency use approval or licensing, okay? So we know that it's safe, we know that it works. What we don't know is how long that protection will last. So far, we know that it lasts 6 months, 8 months, at least. When you know how long that protection lasts, then you would give a full approval. Okay?
So the takeaway point is that emergency use authorization has little or nothing to do with safety. Sorry,
Right.
has everything to do with safety and efficacy.
Right.
Because the unfortunate narrative out there is that EUL does not give some people confidence that the vaccine is safe and effective.
Right. So the key thing, Minister, is that if you do have adverse effects if you're testing a vaccine and you're looking to see are there any adverse effects, severe adverse effects. If that would happen, it's likely to happen in the first 2 or 3 months after you give the vaccine. And so those trials that will run for at least that length of time. So we know that these vaccines are safe. It is, I don't think there's any other vaccine that has caused problems, 2 years, 3 years down the line. But of course, you want to see how long does it protect against infection. So that's what the difference is. It's safe, it's effective. All we don't know is how long does that protection last.
Very important point of clarification. And let's go to 98.1 FM for a follow-up question, please.
Thank you again, Ms. Alcantara. Just my final question, and this can be addressed by either Minister or Professor Carrington. It's a question I asked on an earlier occasion, and I wanted to get some further clarity. To what extent, either Minister or Professor Carrington, to what extent our vaccination initiative has been impacting on the issue of hospitalization? Of course, we are ramping up the system in terms of vaccinating persons, but is it too early to say what the impact of the vaccination program has been having on the population and with respect to hospitalization as well?
Okay. Thank you so much. Now, I don't have the numbers for Trinidad. I'm not the right person to give you the numbers for Trinidad to know if we've seen enough cases and enough deaths to know where we are with respect to that. But what I can tell you is that in places like the UK, their rates, the case fatality rates have come down massively. So you will see a lot of, in the media, you will tend to see things saying this population has been highly vaccinated, and yet they're seeing a surge in infections. Yes, they're seeing a surge in infections, but what you're not seeing in those highly vaccinated populations is a surge in deaths and hospitalizations and deaths. So they do decrease the chance of hospitalization and deaths, massively. I think I read in the US right now, something like 99% of the people in hospital are unvaccinated people. All right? Okay, unvaccinated people. So the chance of ending up in hospital if you're vaccinated is so much lower than if you are unvaccinated. So it's very important. So thank you for that question.
Thank you very much, Professor Carrington. We have come to the end of this morning's media conference. Very, very happy for all the clarification and all the emphasis. And to paraphrase Professor Carrington, vaccination is about you and me coexisting in a community. So everyone step forward. Let's protect ourselves, protect others around us, and please let's vaccinate TNT.